Well, welcome. We know that recovery has never been one size fits all. Real transformation becomes possible when people have choices, have accessibility to care, and a community willing to meet them where they're at. So, strap on in for another episode of Cruising on the Edge. I'm your host, Carol Cruz. And if this is your first time here, please, sit down and relax. I'm here with my guest co host, John Hamilton, here at Liberation Programs. We're here in his conference room where we're going to be also featuring leadership on edge. So John is going to definitely fill us in on what he's been doing here at Liberation. He is a leader in all things recovery, treatment, advocacy. He definitely pushes forward a lot of policies, and also he's just very supportive to people that are in long-term recovery or trying to seek recovery. Also, today's episode is called Recovery Without Limits, Expanding Choice, Care, and Connection. So, John is also, like I said, the CEO of Liberation Program. He is also nationally recognized leader with over 3 decades of experience in addiction treatment, prevention, behavioral health, and recovery supports. He has served on numerous state and national leadership roles and has helped shape treatment and recovery services here in Connecticut and beyond. John is also a longtime friend and also former employer. And I have had the privilege to working with liberation programs before COVID, but we continue to support each other in our endeavors and on this professional and personal journey to help people that are struggling to find some support and help. So thank you for joining me today, John. I really appreciate you.
Thanks for having me, Carol.
Yeah. Why don't you move over just a
All
little
right,
bit, just
sure.
so we're all in the
All right.
camera here?
Wait, look at the
Okay.
camera.
Yeah.
You.
You can look at
All
me, you
right.
can look at the
Sure, sure,
camera. It's
sure.
all
Okay.
good. It's all good. So, before I get into like the depth of questions, well, this is a question. What drew you to getting involved with addiction treatment and recovery?
Family. I had a dad that never found recovery from alcohol and ended up dying from alcohol-related illness. And I had a sister that did find recovery when she was a teenager, and there's many years in recovery. So I've been able to see recovery work for people and not for everyone.
Yeah.
And so I was fascinated by being able to have that experience of helping others, even though I was quite humbled in my own family,
Mhm.
realizing how powerless I was in being able to get my dad in recovery and get my sister in recovery. It wasn't really my work, but I think that's helped me have a healthier understanding of my influence with other human beings in my life and being able to just be there and in some safe space for them.
I appreciate that. I hear that story, and I didn't know that part of your story. But I do hear that a lot. It happened with me as well. My mother, I can remember packing her bags to go to Mount Carmel Guild in Paterson, New Jersey. And I was 12 years old, packing her bags, her going off to a 5-day detox. And she stayed sober for 24 years thereafter before her passing. Actually, today is 28
Yep.
years that my mom passed
Yep.
away. So, yeah, family connects us. And then what did you decide to do going further into your career? What brought you into the career after
Well,
that?
I was always fascinated, just like observing people. I'm very
Hmm.
curious about families and how people interact. So I went up to Marist College and got a psychology degree there, and did my first internship in a psychiatric hospital in Poughkeepsie, and then I moved to Connecticut, and my first job was at Fairfield Hills Hospital, and I was working in the psychiatric units there, working overtime because I had a young family, and I was needing to put some hours in, and I ended up working in a drug treatment program called Eden House for an overtime one day, and I just fell in love with the work, and I fell in love with the people, and I never looked back. And then I became a counselor there, and I really loved the work I did there as a counselor, and I recognized pretty quickly that a lot of people that seemed to do well had family involvement. So then I went back to school and got a family therapy degree. So I'm a licensed alcohol counselor and a licensed family therapist to have the ability to understand systems. And I think that actually helped me. Um, in my work as a CEO in agencies, as well as understanding systems and trying to replicate systems as a healthy family. Enjoying your mate more than your kids, not to infantilize the people we serve, but to be able to recognize that the clients are going to come and go. So we need to have each other's back, have
Mhm.
rational authority, be supportive with each other. And I feel like that's kind of helped me in understanding systems.
I love that, because I think a lot, and I'm not going to say all leaders or all those that CEOs of, treatment centers or, outpatient, inpatient, detox and things like that. I'm not saying that they don't all have something like a lived experience, a family member like yourself. But I think you have something very unique that others don't, especially I've worked for several different, and I can tell you, even though the short time that period of time that I worked here at Liberation, you knew that you could trust as a person walking in recovery. I knew that I could trust sharing my lived experience and not feeling the set of stigma and judgment. I'm not saying that other CEOs or leaders in other organizations don't have that sense of empathy and compassion. I think it's more numbers driven because of grants and things like that. And I know that's probably top. You want to get people paid. You need to keep the organization running like oil machine. But at the same time, is you need to have that human piece to it. And I see that you bring that to the pace.
Thank you, Karen.
Yeah,
Yeah.
thank you. So, looking at how the treatment industry is right now, and how has it evolved, since you're in your career, in
Yeah.
your early days in your career? How has it?
I've seen it evolve
Mm-hmm.
tremendously,
Yeah.
and as I started my career at Fairfield Hills Hospital, there was a separate program for alcohol
Mm-hmm.
and a separate program for drugs. I actually started my career in the program for drugs, which
Okay.
was called Eden House. Independency of Narcotics was what it stood for. It
Okay.
evolved into a Berkshire Woods, it called later,
Mm-hmm.
when it actually
Yeah.
merged with the alcohol program. But initially in the field, I witnessed that drug treatment was separate from alcohol treatment, even though so many people coming in were polysubstance users.
Mm-hmm.
And they had a model there that had some great components and not so great components. It
Yeah.
was a therapeutic community. And pretty quickly, I realized that the concept in the therapeutic community back then was to kind of break people down to build them up again.
Like
Uh,
daytop.
yeah,
Yeah.
yeah,
Mm-hmm.
which stands for drug addictions, drug addicts yielding to persuasion.
Yeah.
Is what Daytop
I've heard the
initially
horror
started for. At
stories.
least that's what the rumors on the streets have.
Yeah.
But there was a sense of community. The community being the healer, I think, was something that was a great foundation that I learned a lot from. But back then, the idea of breaking people down to build them up again, it was pretty clear to me that people were pretty broken when they came in,
Right.
and that they didn't need to be confronted and shamed, that they needed love.
Mhm.
And that's what really made a difference. So they have evolved those programs. They even call it now treatment communities of America instead of
Mhm.
therapeutic communities of America, to kind of distinguish from that past practice. Um, and what we did when we were there at Fairfield Hills, when the drug program did merge with alcohol treatment, is we tried to bring the best concepts of both, self-help support from the alcohol, and then behavioral interventions, and even recognizing that a lot of the treatment happened outside of individuals, groups, and family therapy, when the clients in the community had the ability to have peer support and peer involvement with each other. And building that community, I think, was really helpful. It also helped me grow as a human being, I think, because back then, the staff could get put on the hot seat.
Mm.
Encounter group was where anybody could kind of go off on somebody, because it was all about delaying immediate impulse control. If you're angry, you couldn't get angry in real time, and you would write a slip. And then if I was upset at you, Carol, I would write a slip. And then Wednesday we go to a counter group, and I could tell you off for what you did, and what, or, in a way that was hopefully gets to a place of being therapeutic.
Mhm.
But the great news there is, if I was a staff member and you were a client, you could drop a slip on me, and you could tell me off if I treated you in any way without dignity or respect, and disrespected you in any way. I was held accountable. So I felt like that was really helpful and empowering to me because it helped me learn so much by when I did have a misstep, and I had many, I was called out on it.
Yeah.
So that ability to be held accountable, I think, was a great concept. So that was the first iteration of what I saw, and which was 40 years ago, by the way. That I was a kid. I came right out of college, and that
He's still a kid.
alcohol and drug was separate, and then I saw that that was the first bifurcation, as you would say, the separation, and then the next was the idea of addiction treatment with mental health,
Mhm.
and the idea of co-occurring disorders was like the next evolution of recognizing that co-occurring disorders, as Ken Minkoff it says, is the rule, not the exception. I
Right.
think that's the next evolution of what I saw happening. It went from alcohol and drug to uh, chemical dependency, they called it back then, to the understanding that we also had to address some of the mental health
The
issues. So
dually
the
diagnosed.
duly
Yeah.
diagnosed and
Mhm.
being able to work with those individuals as well.
Right.
And then I watched the evolution of it being initially when I started the career, there was methadone in residential therapeutic communities for somebody that had a substance use disorder that was like opiates or a drug problem. And for alcoholics, there was AA, and that was the only treatment pathways, or like three, pretty much. I've seen the multiple pathways evolve, and that's been pretty exciting. And
Yeah,
being
it
involved in
is.
CCARs, I know that you also have been involved, and you were our first family recovery coach, by the way,
Yes, I
probably one of the
was.
first in the state. So that was pretty cool. So that I've seen that evolution, and now of recognizing multiple pathways in recovery, and now more integration into primary care and housing and other kind of wraparound services, and recognizing the social determinants and some of the impact on the field. I've seen it really evolve, a lot more focus on trauma and trauma informed work. I've seen it, come to a place where people are more open minded to see what works. And I had the privilege of working with NIDA, and then I actually chaired their dissemination
NIDA
committee.
stands for.
National Institute of Drug Abuse, which was, I think, responsible for 80 and 90% of the research of an addiction in the world. And they do phenomenal work in these multi-site clinical trials and all, but there hasn't really been much innovation that has come out. Well, what I learned through all the work there is that different interventions work for different people at different times in their recovery period.
Mm.
And there isn't this one size fits all. So it's so important to be able to have different options for people to help them find their own pathway in recovery.
What an amazing transformation. And I know you've probably shared that many times in a presentation. I've seen you do a lot of presentations, but it always sounds new, especially we haven't seen each other in a while. But I hear the transformation, and that is what, I said in the beginning. Recovery is not 9 to 5. I'm a person in long-term recovery. I will be celebrating 32 years this September. My son will be 32, and it was going to Project Courage, Women and Children's program that finally accepted me. But back in the day, I couldn't be on methadone and go into an outpatient
Yeah.
program. I was risking the other patients or the other clients' recovery. And they didn't want to see me nodding out, which, yes, methadone can cause that, depending upon the dosage and things like that. But, the one size fits all, 9 to 5, that's not recovery. That might help in stabilization for treatment. Like you need to be consistent on treatment, but not everybody is cookie cut. We're not,
Yep.
my recovery is very different than my ex's recovery. And
Yeah.
he's, just celebrated, gosh, 4 years, 36 years, 36 years of recovery. And so looking at, um, I know if in those early days too, I didn't have choice. I was under the Department of Children and Family.
Yeah.
I had to, abide by their rules. Luckily, they only kept my case open for a short period of time. Once I got off methadone, I had an amazing DCF worker. Her name was Paulette Lorette. Wonderful person. She would show up in my house and she'd check on my son, make sure everything was good there. The visiting nurse had come in, to check his vitals and make sure his weight was well and doing well because of my use during my pregnancy with him. But her and I would sit at the table and we would literally shoot the shit.
Gotcha.
And we smoked cigarettes back then, of course, away from my son. But she treated me like a human being. She took that badge that they all wear, right? We all wear, well, you're not wearing a badge, but if you're in certain spaces, you have to, right? To get into whatever the building to show that you work there, period. And she would take that badge and she would flip it over her shoulder and she would go in for the hug. And I would be like, oh, like, so yeah, I didn't want anybody to touch me because of the shame, the guilt, that I was also not only here feeling inside, I was seeing it and feeling it in treatment spaces. So we've talked about multiple pathways and harm reduction. I now can say that I'm a harm reductionist. I took actually when I worked for Liberation, we had the gentleman from Hartford. All of a sudden, his name just went a blank. With Hartford,
Jenkins.
Mark. He did the training and had us. It was real fentanyl, and there was
Yeah.
fake fentanyl, and we were all testing it. We were trying to remove the myths, and that's what I realized as I'm not only a person in recovery, I'm also that advocate that can not only share my story, but also break that stigma, break that pathway of why people don't want to
Yeah.
enter treatment. So in regards to the holistic, the essentials, what other areas of the multiple pathways are you most connected
Yeah.
to?
And it's funny that the multiple pathways concept, as you said, is still relatively new.
Mm-hmm.
I joined CCAR on their board 20 years ago
Yep.
because they didn't really recognize methadone as a multiple pathway. And they had a great drop-in center with one of the leaders in the field, Michael Askew, as you remember. And some of them are methadone clients that were on medication-assisted recovery, which most of the time included methadone, didn't feel welcome. And so we were able to get methadone on kind of as a pathway to recovery. And now, people that are on medication assisted treatment, some of them are running those drop-in centers. So
Exactly.
it's come a long way. And I think the last piece, and you touched on it, is this harm reduction. It took me a minute to realize that harm reduction is on the continuum of a
Mm-hmm.
recovery path. It's not at odds.
Yeah.
It's meeting people where they are without an agenda.
Mhm.
I do think, the idea of recovery coaching, asking these eloquent questions like, how can I help you in your recovery today? And, what does your recovery look like to you? Beautiful questions. Um, but it's for that 1 out of 10 people that are ready to, embrace recovery. And we want to keep the other 9 out of 10 alive. So I've seen and I've learned through our work with our outreach team and our people doing harm reduction that, they really do meet people where they are. For years, I used to say, meet people where they are and treat them with dignity and respect. And I felt like we did the best we could with what
Don't
we
leave
knew
them there.
and don't leave them there.
Yeah.
But we also met people where they were at the
Mm-hmm.
time with an agenda. I'll meet you
Outside.
where you are, but I want to get you in recovery
Mm-hmm.
versus maybe you need a meal. Maybe you need housing. Maybe you're unhoused.
Exactly.
So meet
That's what I
people where
mean.
they are without an agenda is what I learned from harm reduction.
Mm-hmm.
It's funny you talked about your DCF work or treating you like a human being.
Mm-hmm.
I had the opportunity to help set up the voluntary treatment system in Vietnam a couple of years ago,
Okay.
and they were just where we were maybe 40 years ago. They saw drug use as a moral failing.
Mm-hmm.
Their department that was equivalent to SAMHSA is the Department of Social Evil Prevention and Control. So you have work to do. But that's where they were. So it took me a while to actually train their staff and, all well intended, but they were putting people in these work camps where they were like bottling cashews and they were calling that treatment back like the old TC days of
Right.
therapeutic communities of like job function. And it really wasn't, treating people with dignity and respect. But only when I brought their leadership here to Connecticut and had them come to our treatment programs like Families in Recovery to see, women not having to choose between, their children and their recovery and seeing these programs operate, the person that headed the department said, I get it now, John. You have to treat them like human beings.
Yeah.
Again, it's kind of where some of the
It's a no-brainer.
yeah,
It doesn't take a whole lot of science.
yeah,
I think it's a practice, right? We may not be born with
yeah,
the sense of empathy and compassion,
Yeah.
family dynamics, right? Family of origin
Yeah.
could be very much the catalyst of how I respond or how I react. When my mother was in active alcohol use, I was also trying to manage my own abuse, not abuse to drugs and alcohol, but
Mm.
other things that were
Yeah.
happening to me at the time because I was young, and not wanting to share those things with her in fear that I was the cause. Well, I was told by my step parent, my stepfather, that if I shared anything that was going on, I was the cause
Yeah.
of her
Like you were
alcoholism.
responsible for
Yeah, and I
recovery.
think also too we carry that trauma, and I loved how you talked about, trauma informed care. We hear person centered care, right? We hear of also stabilization, right? The stages of
Yeah.
recovery, getting a person stabilized. Some people say, I'm glad I went to jail
Yeah.
because that, woke me up. Well,
Yeah.
yeah, that may have woke you up and you went off to a meeting and you've been a one time wonder, but that's not everyone,
Yeah.
right? I came in through the rooms of Alcoholics Anonymous and Narcotics Anonymous. And yes, I'm still here because of
Yeah.
those groups and those meetings and that community. But I knew that there was something more because there was still stigma in the rooms. There was also racism in the rooms, and being a woman of color, that was concerning. How am I going to recover in this community if I still feel like I'm an outsider? And I think what we do today with harm reduction is we're not pushing it on someone, we're not pushing medication on someone, but we're saying, hey, we can help you get stabilized, but it's really your decision. But we can also help you build community. We
Yeah.
can get you
Yeah.
connected to a food bank or housing, get your
Yeah.
applications out there. That's what I did
Yeah.
as a recovery
Yeah.
coach. I help people fill out applications, housing
Yeah.
applications. I
Yeah.
took them to doctor's
Yeah.
appointments. When I worked up in New Britain, that's what I did. Why? Because it was really important. No, I wasn't their chauffeur, but that gave me an opportunity to also have a conversation. And you talked about that with Mark Jenkins, and I remember him also sharing it during training. Is that it's about having a conversation. He loved the whole concept of a recovery coach. And he said, but the bottom line is, I need to have a conversation. I want to have a
Mhm.
conversation with this. How's the kids? Did you go on that job interview you
Yeah.
talked about
Yeah.
the other day?
Yeah.
Hey, we have some supplies in the back, just stop in, because it was a storefront. We still see, even on the state level and the federal level, they look at us as, they look at us as we're not worthy of living a full life. And recovery shouldn't be this hard.
Yeah. Yeah.
It shouldn't be this hard. And I never like to should on myself or should
Yeah.
on anyone else. And I don't like to call people out. I'd like to call them forward. But some people deserve to be called out,
Yeah.
as far as when they're making their decisions for me. Because
Yeah.
don't
Yeah.
make decisions for me that are potentially going to cause me, I'm not going to say that they cause me to have a relapse or a
Mm.
reoccurrence, but at the same time, if you're going to cause the stress that I've worked so hard to get through this period of time in my life,
Yeah.
and now I've hit another stumbling block, and you're not giving me any alternatives,
Yeah.
any route to that,
Yeah.
well, I might as well go back to
Yeah.
the way it was and just numb myself out.
Yeah, I have to think that the leaders in this field and all of those staff in this field
Hmm.
need to have that key core component that is thread through, I think, most pathways of recovery, which is humility.
Yes.
We don't know what's going to work for people. And we all come from a bias, as you even mentioned before. If you've had a good experience with somebody,
Hmm.
family, friends in recovery, then you'll believe in recovery. If you didn't have a great experience, you might have a bias against it. But yeah, everyone has a bias, right? So we have to really, to meet people where they are, we have to ask more questions. We have to all be like Ted Lasso.
Get
We've got to stay
curious.
curious,
Yeah.
and not judge and have that humility because again, that's what I felt like I learned from all the work with NIDA, and I met some pretty brilliant researchers, across the world.
Hmm.
And what I learned was that we don't know what works for each individual, and even with AI. there's no predictive modeling and adaptive treatment models, but I do know it goes in my mind that if you look at the old Maslow's hierarchy of needs,
Mhm.
and the basic needs being on the the bottom of the pyramid there,
Right.
we have to have some humility and recognition that unless a person has these needs met, of basic needs of like housing and employment and working on their trauma and feeling safe,
Right.
in their own and comfortable in their own skin, we can't even start a conversation about abstinence, right? So I feel like in many ways we can do a better job just giving people support for what they need instead of coming in with our agenda over a continuum, and being able to work with engaging people by really just being better listeners.
Yeah, absolutely. And, what would you say are some of the things that you may be working on here at Liberation, or you've talked about in leadership spaces in regards to what do we need to do to keep the momentum going? I think one of the things that was really relieving for me is that I knew where to access care,
Mhm.
right? And anyone that calls me or I see them, I work for a crisis call center, so but there it's not in Connecticut, it's all in Massachusetts. I work from home, so I'm connecting them to resources, but I don't see them, I don't hear them. So, what would you say? Is something that you all are working on to kind of bridge that gap in connecting families,
Yeah.
connecting individuals to treatment, to recovery, to community.
Yeah, yeah. I think the key is collaboration.
Mhm.
Knowing what we do well and knowing what we need to be able to collaborate with our partners in the community for to truly have a no wrong door approach.
Right.
People say they have a no wrong door approach, but sometimes again they have their own bias, they have their own agenda pulling somebody into their services. And what we need to do is really find out, are we the right place for someone? What are we providing them in that holistic care? So I think there is more of a movement towards integrated health, not just again with that next iteration of mental health and substance use disorder working closer together, but primary care as well. But I think we also have to pull in like law enforcement. We have a new
Yes,
program that we're
yes.
working with,
Oh,
and we're partnering with McCall, and it's really become wildly successful,
mhm,
called the Clear Project, which is actually it initially started to have a response when police would respond to an overdose, that we would provide them with a recovery coach and a family recovery coach to give their families support. But again, that's a small number of individuals that are ready for recovery even after an overdose, and they're at greatest risk for another overdose.
right.
So we found that we not only have to, provide them with recovery coaches and family recovery coaches if they are ready for that,
Mhm.
but also our outreach team if they're not, which
S
is to keep them alive and be able to work with them. So that program has evolved to now police identifying individuals that could be at risk of an overdose,
mhm,
and again deflecting them into treatment.
right.
So there's a full continuum in the criminal justice system, as you know, and these points of intercept. And we're, really big on trying to keep people out of the criminal justice system, because on top of everything else, it's hard to, find employment with a criminal record.
Mhm.
So, and it's just not, it doesn't work,
Right,
from the
right.
standpoint of, long-term outcomes. So, to deflect is to keep people out and not have them have an arrest. And then diversion is once if there is an arrest and necessary, then you give them services. So now that's expanded into first responders. We work with, like in Stanford, the transit authority, because there was like 87 people living at one point, sleeping in the train station a
Mhm.
night, and we had our outreach team bring that number down to like the teens now, and we're still trying to find housing for everyone.
Yeah,
But they even gave us an office there because they see the issue. So,
right.
and Stanford Hospital also saw some of the issues, and we integrate with them. And they also saw post-COVID people coming with more anxiety and depression. So now we're embedded in their primary care
Mhm.
in Greenwich and in Stanford. So if you're meeting your doctor and you look a little sad, and your doctor asks you, "Have you been
Mhm.
sad lately?" Then we'll bring in a therapist to be able to work with them in real time.
Right.
So that's kind of more the
Not
future
3
of what we're
weeks,
trying to
not a
do.
month from now.
Exactly,
Yeah,
exactly.
yeah.
And then now we're also with this clear grant, we're working with Department of Corrections to have people reentering, returning
Mhm.
citizens, reentering individuals, give them support services that they might need as well once they get in the community. And then there's a handle with care model, which is identifying if a child has witnessed some trauma of an overdose, for
Right.
instance, that identify them in the schools of needing to be handled with care so we can give them family supports. I feel like, and I know you were on the forefront of this with families, we
Mhm.
have a lot more work to do
Oh,
with
yeah.
families. There's just not enough support for families, not only in being able to navigate treatment for their loved one, but to be able to
Treatment for
find
them.
treatment for them and
Yeah.
recognize
They
they're
don't
healing.
recognize that they're
And
in recovery
exactly.
or they're on a
Yeah,
pathway to recovery too, and they're very guarded.
exactly.
I get that from, just in real time now, I'll get a call from a parent that's in California and their loved one is in Massachusetts, and they have all the everything that needs.
Yeah,
They're telling me what they need, which is fine, but realistically, what are you doing for yourself? Yes, we want to immediately, as a parent, we want to save, we
yeah,
want to rescue. I get those calls every once in a
yeah,
while from my son, and immediately I want to jump into action. And what the best thing I can do is just be present,
yes,
right? But also, too, it's not cookie cutter.
yeah,
And
yeah,
I think parents, and again, this is not going to, not every parent or loved one, family member is going to be on board with this because they don't want to get rid of their
yeah,
deep dark
yeah,
secrets. If they even think that they're at the root of why their
yeah,
loved one is in the place that they are. I know my mother, she carried a lot of guilt.
yeah, yeah,
She was like, well, I was hoping you wouldn't be an alcoholic like me. And I said, I'm not. I'm a drug addict,
yeah, yeah.
but
You distinguished yourself.
yeah,
Some
and
level
I
of
took pride.
differentiation.
I took pride in that for the
Yeah,
honest reason
yeah,
because it was normalized in my time.
yeah,
But at the same time, is not having her understanding. It took me that much longer. I knew she was there to support me, but at the same time, is I didn't want to burden her.
yeah,
And I think that's what I hear from a lot of people that are still out there struggling or have
yeah,
had several reoccurrences is that, well, treatment, I've been in, 20 different treatment centers over the last
yeah,
5 to 10 years, and it didn't work. Well, maybe it didn't work because it wasn't the right treatment,
yeah,
right? It
yeah.
wasn't the right,
The right time.
centered
Yeah,
care. It wasn't, tailored to your needs
yeah,
specifically. Maybe you got what you needed therapeutically, but then you didn't get connected with community,
yeah.
and so we know that, like, what did they say? The opposite of addiction is
Connection.
connection,
Yeah,
right? And making those connections can help in the
yeah,
transformation, can help in opening us up to curiosity. What do I want to do now? Well, maybe I want to go back to school. I was 51,
yeah,
recovery
yeah,
31. So 20 years later, I decide I'm going to go back to school. And
yeah,
graduated with an associate's here at University of Bridgeport. Am I good with that? Absolutely. I don't want to go back to
yeah,
school. I like what I'm doing right now.
yeah.
But go ahead.
I
You
was
want
going
to
to
say?
say that, I feel like we've done great work with like recovery oriented system of care, recovery friendly workplaces, recovery friendly language. We really haven't caught up with recovery friendly language when it comes to family.
No.
We still use terms like
Enabler.
enabling, and enabling is just showing love the best way you know how.
Mhm.
And our like modest goals in our family work at liberation programs is to redefine relationships in a manner that promotes recovery for your loved one,
Mhm.
but also promotes recovery for you
Right.
and recognizes and distinguishes that your recovery process is independent of your loved one. So again, that sense that, shame doesn't work as an intervention.
Right.
So we know that from the individuals trying to come into treatment. It also doesn't work for the family. And it's another obstacle for stigma, the shame of families feeling like they've done something wrong.
Right.
It's like that other concept, dysfunctional family. No
Mm,
such thing as a dysfunctional
yeah.
family. Every behavior has a function.
Mm,
We just have to pay attention to how this behavior worked for this family until it didn't.
right.
And then, they did the best they could with what they have and get to some level of acceptance. It's not to say that there's terrible things that have happened in families and in troubled families that are challenges, but the last thing they need is another label and to feel shame like they were less than when everyone was doing the best they could with what they had.
Well, again, with with families not being well informed, or they are well informed, but they still have their own perception of this person's doing it. It's a choice.
Yeah.
It didn't run in
Yeah.
my family. Yeah, it was an
Yeah.
uncle three
Yeah.
generations ago that had an alcohol problem. But why, why do you have a problem? And that can be, again, a barrier to individuals. And then also, too, I'm thinking how families not only create the barrier where there was a young lady that I worked with over there at Liberation, and she was pregnant, and we were trying to get her into the Women and Children's program that you have, which I think I had it back in my day, but I think I was too far gone in my
Yeah.
pregnancy to be able to go. And what the barrier was, her partner. Her partner didn't want her to be on methadone.
Mhm.
And right there, it was hard for her. So she had to choose,
Yeah.
right?
Yeah.
She had to choose between her unborn child, her addiction, and this individual, her partner. And she did eventually, what I believe, because we had one or two conversations via Zoom when COVID hit, because I had like 30 people I was working with, and unfortunately it kind of dwindled down to a
Sure.
couple
Yeah.
because we weren't
Yeah.
set up, for telehealth back then, especially me as a recovery
Yeah.
coach, and
Yeah.
the legalities behind it and everything. But that I hear that more and more is that families don't want to be the enabler, get that label, but they also don't really understand
Exactly.
why
Yeah.
medication is
Yeah.
important. Why isn't medication like fixing you right now?
Yeah.
Like you should
Yeah.
have been, oh, you're going to those meetings, you should be fixed. You should be okay. Why are you struggling with all these other things?
Yeah.
But also too, it's triggering them.
Yeah.
They're
Yeah.
getting the vicarious trauma
Yeah.
from, and it goes back and forth, back and forth. So it is barriers, I think, need to be explained. What programs do you have here? Do you have like where families can come
Oh,
in and talk,
absolutely. Yeah.
what's that look like?
And to your point, Carol, like in our medication assisted treatment programs, we
Mhm.
offer all three FDA approved medications,
Mhm.
the injectable naltrexone, buprenorphine, and methadone. But to your point, what's so key is to educate families who
Mhm.
wouldn't know what methadone is all about,
Right.
and have an understanding of the value of that in their loved one's recovery, so they are at least they're able to support their loved one's recovery with a sense of understanding of what that's all about. Otherwise they're making the decisions that are like in a vacuum. And the other phrase that you hear a lot of, again, that I think needs to be addressed is tough love.
Oh
There's
no.
two
Let me
mutually
throw
exclusive
them out.
concepts. Yeah.
That.
There's tough and then there's love. I understand that families want to feel like they have agency to do something different, but those interventions are for the family. They
Right.
don't have any outcomes to show that they help the loved one.
No.
So like lead with love. I understand that sometimes people have, need to kind of redefine their relationship and pull back for their own recovery.
Mhm.
But the idea of being tough, if you think that's going to help your loved one,
Right.
you may be their lifeline. So I would be really reluctant against that. So again, the family involvement is really to understand what treatment's all about.
Mhm.
And methadone, for instance, still there's stigma within a stigma.
Yeah.
And there's been a study that was really, I like to tell everybody about because it's such a wake up call and shocking. 2016 and 17 study here in Connecticut. Robert Heimer and his colleagues at a school in epidemiology at Yale did this study to look at the mortality, the deaths of in Connecticut in 2016 and 17, and their exposure to treatment 6 months previously.
Right.
And if somebody was exposed to uh, buprenorphine and actually decreased their likelihood to die by like 38%. If they were exposed to methadone, it decreased their likelihood to die by 58%. This is why this is the gold standard.
Yeah.
Although it's skills and pills, not
Mhm.
skills over pills, but
Right.
both you need to be necessary at times. But even with the pills, it quiets the brain, then the miracle still has to happen. You still have to do the work.
Right.
But 58% reduction in overdoses if person was exposed to medication. But the scariest thing about that study, the biggest wake-up call, is if you were exposed to a 30-day abstinence-based program for opiate use disorder,
Mm.
it increased your likelihood to die by up to 70%.
Yeah.
So, which makes sense if you being in the
Right.
field, you know this because,
Forcing them into
yeah,
one box, of
exactly.
abstinence. And that's where, 12-step programs,
Yeah,
again, they save people's lives.
yeah,
But not everybody is ready to completely stop. And that's where
yeah,
harm reduction and, we can go back to the earlier days of understanding harm reduction. A condom's harm
yeah,
reduction. A seatbelt
exactly,
is harm reduction.
exactly.
A fire extinguisher
Yeah,
is harm reduction. Drinking milk before hitting
yeah,
the
yeah,
bar, coat my stomach, which those are things that are harm reduction. And sometimes we do have to break it down to the most simplest
yeah.
point. And also, you were
What I want to point out, first do no harm.
right,
Sometimes
right.
going into treatment was going to do more harm.
Mm-hmm.
And the reality is that's 1 out of 10 people that in 2026 that could benefit from treatment, qualify for treatment, are going to access treatment.
Right.
So we're trying to keep the other 9 out of 10 alive. We're not recognizing that 1 out of 10 that comes in, those people that come in our doors at liberation programs or any other
The
program in the
numbers don't
state,
lie.
they're coming in with a gun to their head. They're either mandated or mom dated. They got family support. They that's pushing them and pressure, or somebody in their life, that's putting pressure on them.
Mm-hmm.
So that's the danger sometimes for people coming through treatment. They're coming in with external pressure, and so they're going to go in and be compliant. They're going to say what they need to say, do what they need to do to get the heck out of there, to not disappoint their family again, or their sponsor, or their recovery
Check
coach.
the box.
But that's why it's dangerous when the person leaves.
Right.
They could be off to the races, and now they have no tolerance if it's an opiate use disorder. So if they use the same amount, they're more likely to die.
Right.
And the other part is they just went in for someone else. They don't want to let them down again. They don't want to. They feel this deep sense of shame if they're going to go back to do their drug use. So they're probably going to do it in secrecy and private,
Right.
and there won't be anybody around with Narcan to keep them alive. So we really have to, and what we did and adapted a model now at Liberation, that if people come in to residential treatment in our residential programs, they get an informed consent before they leave that tells them the risks and benefits of not being on medication and on being on medication, but in particularly emphasizing the risks if they're not on medication, for relapse and their recovery. And we give everyone Narcan when they leave, and all family members as well.
Yeah. Everything that we've been talking about, again, I come back to this is the only disease that we have to explain to people that we have a disease. We don't
Yeah,
have to do it with cancer or
exactly.
diabetes or heart disease. And we're still in that place. I mean, yes, the numbers don't lie. We have the facts. We see it on
Yeah.
a day-to-day basis. Even though I'm not out there in the community, I was able to talk to a woman like 11 o'clock at night. I get off at 12:30 a.m. She called in, she's pregnant, similar background story as mine. Um, she's like, I don't want to be in the same town. I don't want to be in the same town where people can pick me up out of treatment, like get me out of town. And now I'm looking for access to a treatment bed. And I can't promise them because I don't have in real time whether that facility has a treatment bed. Plus, this is a Saturday
Yeah.
at 11 p.m.
Yeah.
And so it isn't around the clock where that would be like the perfect world.
You
Yeah.
said we have a chronic addiction is a chronic disease. We have a chronic disease
Yeah.
that we have a treatment model that treats it like an acute disease. That's
Right.
we have a treatment model that's fragmented,
Mhm.
and people fall through the cracks all the time.
Mhm.
We've got to do a better job actually providing more support over time.
Right.
And what we do know, and again, this goes back to the idea of like we don't have any prediction of what's the best pathway for individual, but we do know if we overall build somebody's recovery capital and they get to a certain threshold, they'll be fine. But we don't know what that recovery capital is. That's the magic, number of like key components of what that individual needs for sustained recovery, and which pathway, and which medication, and which recovery
Which
coach
are
is
all
going to be a good
capital.
fit.
Because I was going to ask you to explain a little bit about what
Yeah.
recovery capital
Yeah.
is for those that are listening in, and recovery coaching. That was for me like the starting point when I became a recovery coach and I was working with young adults and families, that sharing that capital and helping them to even recognize the capital that they already had. But
Yeah,
now how do we enhance that?
exactly.
How do we enhance that? Well, maybe it is disconnecting from certain things. Maybe it's just temporarily. I need to disconnect to certain things that were part of my active use, and maybe I can integrate them in later and see them as capital.
Yeah,
But let me connect these folks to, when I even think about the unhoused, right? Some people say, I don't want the housing because I don't want to be told what to do. Okay, so the capital, what's the capital? What would be the capital out of that point? How would I help that person to recognize, yes, they need to get someplace safe, but I can't force them,
yeah,
to get in. They've been waiting for years to
yeah,
get their application has now got pushed up
yeah,
and they've got housing, but now they know they have to follow all these rules,
yeah, yeah,
right? So it's not helping them fill out the application. It's helping prepare them to
exactly.
what's next.
Yeah,
I think of the 5 W's that
yeah,
I always
yeah,
incorporated in my training. It wasn't part
yeah,
of, the C card training, but I incorporated from a different training. What's missing? What's missing in your life?
yeah,
Well, I miss my family. I want to get reconnected with my family. Well, how can we do that? What would you want to do next? What's working, what's not
yeah,
working, what do you need? When was the last time someone asked you what you needed?
yeah,
You're out there in the streets
yeah,
and you're running,
yeah.
rip roaring and
That
running,
should be the first question.
yeah,
Yeah,
but
yeah,
it's not. Yeah, it's what
yeah,
you need
yeah,
from the drug
yeah,
dealer, but
yeah,
no one else is
yeah,
asking you for what
yeah,
they're telling you what they
yeah,
want
yeah,
from you, which is very draining. But then that what's next, I look at that as the middle point. I can't say a person with 1 week of recovery is not ready for their what's next,
yeah,
but that having that communication as a recovery coach, as a peer support specialist, like I'm getting more and more curious. I'm even putting out, I'm dropping in a little bit of some
yeah,
golden nuggets
yeah,
there, like, oh, I never thought of it that way. Oh, I've had some folks come in frantic, they're about to turn off my lights or about to turn off all my utilities. I haven't paid anything. And they come in, they're looking a little better,
yeah, yeah,
we clean up well, right? I look pretty good. And I'm not biased because I want them to feel
yeah,
better on the outside. Sometimes we need to work on the outside before we can get in, tap into the inside. But at the same time, I'm not going to judge them because they may have used their money to look
yeah,
good.
yeah,
What I'm going to say is, okay, what do we need to do? Well, did you call the
yeah,
utility company? So I'm not there. I am in the sense holding
yeah.
their hand,
Oh, yeah, yeah,
but being there as a support. And
exactly.
community brings that, collaboration brings that,
Yeah.
you
No, and
know?
then, I mean, in some ways, as you said, they're not ready to make that change,
Hmm.
but the less obvious community capital is they came back to you.
Right.
And it's that relationship, it's that
Exactly.
connection that you want to have over time.
Right.
And then as long as you're there to guide them and they believe in you and are able to ask for help
Hmm.
and continue to ask for help and be open,
Right.
there's the capital right there. I think there's certainly, as we talked about, there's so many different pathways to recovery, but there's some common thread. And I think some of the common thread is the ability to be humble, to be able to ask for help, to be able to connect to others. Also, gratitude. When you see people in trouble, they have a lot of resentment. What do they say? When you harbor resentment, joy has no place to dock.
Right.
And the opposite of that is having gratitude.
Right.
I hear so many stories of those that I serve and that are doing well, and it starts with gratitude, being grateful for what they have in their life, and you can build on that.
Mhm.
And it's a lens that can really empower people for agency and give them a whisper of hope. Also, the ability to feel lovable, capable, and connected. Sounds pretty easy for some, and it's quite a challenge,
Right.
particularly if you've had a history of trauma and you don't feel worthy, or you don't feel safe. I mean, you have to feel safe first, and you can be that one
And
safe
safety looks
relationship in their
very
life.
different
Yeah,
for me than it may for you.
exactly.
And again, it's not the cookie cutter. It is being more curious, whether it's through your therapist, through your community, through your recovery community centers, through treatment. It is getting curious. And one of the things working as a recovery coach was, having to re-educate clinical staff. And I talked to one person and I said, as being a person in recovery and being a clinician, I've observed you when you come back after a session with somebody and you seem very angry and almost disappointed in the result of that session. Do you mind, sharing that with me? And they said, it's just so frustrating. And, they use this place as a revolving door. They're, uh, what's the frequent flyers, again, another stigma
Yeah.
statement that can be used
Yeah.
that has been used
Used
in the
against
clinic.
people. Yeah.
Exactly.
Instead of looking at what they did wrong, it's like that idea there's no such thing as a resistive client. There's only a
Right.
staff member who's resistive to paying attention to what that client needs in that moment.
Right. And yes, this is hard work. We didn't get into this field to make
Yeah.
a whole lot of cha-ching, but it is rewarding. But it also, I felt like I was there to not call out this person, but just help them to understand that one of the things that really helped me with Paulette Lorette and other
Mhm.
counselors that I
Mhm.
connected to was that sense of patience,
Yeah.
and how they presented themselves to me and not attaching myself to the outcome. I heard this from a former clinician therapist out in Las Vegas. And she said, yeah, when people come in, we're not only doing intake, we're already setting up for discharge.
Mhm.
And I thought, wow, that is weird because how can we build on an
Yeah.
outcome? Like, yes, I
There's
can
that acute
understand goals.
disease model. Yeah.
Yeah, I
Yeah.
understand setting goals,
Yeah.
but you're already discharging this person
Yeah.
and they just hit the threshold
Yeah.
of the door and you just did a psych evaluation or whatever. So, looking at systems and our funding going on and funding decisions in this administration, how is the climate here at Liberation in regards to what's happening nationally
Yeah.
to what's happening here in Bridgeport? We'll just keep it to
Sure.
Bridgeport for
Yeah.
now.
Well, I mean, we've recognized that some of the changes in the federal funding has impacted negatively
Mm,
some of my colleagues. We've been fortunate; we've not had that in the experience. We've actually pivoted, and we were able to receive new dollars from opiate settlement dollars and through community development block grant,
yeah,
and having our development department actually do a terrific job being able to find foundations that support our cause. We had Cohen Foundation just gave us, $275,000 to furnish Liberation House. We
that's
got Senator Murphy's house office gave us $3 million to renovate that building, which is
yeah,
no
great
building. And
advocates.
so
Yeah.
we're trying to expand more women's only bed because we don't have that in our continuum. We're partnering more with housing
Hmm.
to try to develop low barrier housing. We're going to open a drop-in center similar to CCAR, but for those
Okay.
other 9 out of 10 people that aren't ready,
Hmm.
an overdose prevention center here in Bridgeport. And again, as I said, we partner with law enforcement and first responders to
Hmm.
just be able to realize that we've got to all work together.
Yeah.
I want to go back to something you said about like the idea of sharing somebody's recovery. That idea of self-disclosure, I think, is a
Mm,
pretty simple
yeah.
assessment tool. It's like if you're in front of somebody and you're sharing for their best interest and it's going to give them a whisper of hope,
Hmm.
then it's always good to share.
Yeah.
If you're sharing for
Oh,
your
it's
own,
different.
it's
Yeah, for
probably
sure
not,
now.
right? So
Yeah.
I always tell our staff, no matter what their role is, it's more
Mhm.
important to show people how much you care before you show them how
Show
much
you're
you know,
human.
and honestly, when I do all the research, we don't know much and
Yeah.
we got to be humble,
Yeah.
but we can care more. And we can never care enough. So we just be able to just continue to show up and not start on discharge planning, but start on building, who knows, a lifelong relationship with somebody.
Yeah, I love how even in the recovery coach training, we talk about the hierarchy, right? We talk about the sponsor, the recovery coach, and the clinician or counselor, and what each person's role is. And yes, the sponsor, the AA sponsor, 12-step sponsor, is very similar to the peer coach, but different, right?
Exactly.
We're
Yeah.
doing more
Yeah.
documentation these days. We are integrating more as trauma informed care. We're being out in the community where, yes, my sponsor might show up at the courthouse
Yeah.
with me and be support, but may not be the person that's picking me up to go to meetings and things like that. So I love how we can explain those differences, but also to, like you just said, how they're very necessary to get connected. Well, maybe that person doesn't want to do 12 step, but like I've gotten more into Dharma recovery
Hmm.
and looking at the more Buddhist inspired
Hmm.
approach to
Yeah. Yeah.
my recovery.
Refuge recovery. Yeah.
Refuge
Yeah.
recovery, very
Yeah.
much the same.
Yeah.
And looking at the concept of choice, right? So it's not about the choice of whether I use or I don't use today. It's more, do I choose to be in suffering or do I choose to be
Exactly.
happy?
Yeah.
What
What
do I need
pathway
to do?
resonates for you?
Right.
Yeah.
And what do I need to do? Well, maybe I need to up my game on doing some meditation in the morning or going for a walk
Yeah.
or calling a friend that understands where I'm coming from. What do I need to do to make that shift? Also, having a mentor, someone with lived experience and has come back to give back.
Yeah.
We
Yeah.
talk about it in the 12 step
Yeah.
of
Yeah. Yeah.
recovery.
To
I
keep it,
can't
you got to give it away. Yeah.
exactly, exactly.
Yeah, I
Well,
wanted to mention in the federal changes that there has been a lot of disruption. But again, I always look to see is there possible opportunity.
mm,
But there's also these requirements that they're looking to put in January 2027 for Medicaid that requires volunteer work or having to do employment. That actually, if you were in treatment for substance use disorder, it's an exemption. So again, we meet people where they are. Maybe they may not be interested in considering a recovery program right now, but they might want to stay on Medicaid. They may come to us just so they could stay on Medicaid. And when they stick around, they might find something they like. So again, that could be an opportunity to serve more people. There's also an opportunity with housing that
mhm.
they're looking at developing transitional housing again, like recovery housing with supports, which is great as long as it's not at the expense of permanent supportive housing, which unfortunately there's just a finite amount of dollars. I would hope that they would put new dollars in transitional housing because that
Mhm.
could actually help more people, in a transition, especially in early recovery.
Right, absolutely. When you mentioned about the opioid settlement money, I'm good friends with Ryan Hampton, and we were on the phone last week, and that did GXC
Yeah,
conference
yeah,
was canceled, and I was going to bring the podcast there,
yeah.
but we're going to do something else
Oh, good.
online. He hasn't
Yeah,
launched, he hasn't announced it yet, so they're going to
that's a
mobilize
great
recovery.
conference too. I was disappointed to
Yeah,
hear
me
that they
too.
canceled.
Yeah,
Yeah,
that was gonna be my next ride,
yeah,
for the year and then end the year off. But always Ryan brings it, and he was on the committee
yeah,
there for a very long time and he had to drop off because of the stress. They weren't hearing us. So how do we continue to get our voice heard?
yeah, yeah.
Yeah. I started this podcast because I wanted voices like yours, voices like mine, and
Yeah,
other
yeah.
guests that I've had on. How do we get our continually consistent? Because it's tiring.
It is. I think though that there has to continue to be a whisper of hope of sharing your story because it's like people are changed by stories and there's so many stories of people in
Hmm.
recovery that has an impact. Stories of family members have an impact. They'll impact different audiences, but that's how you change policy is it's not just showing, it's not hitting them in the head, it's hitting them in the heart. And the head sometimes too. But
Yeah.
for some people, again, it's like tailoring your message to your audience, meeting your audience where they're at
Hmm.
means certain, legislators have a different, kind of take on what's going to resonate to them.
Right.
So again, emphasize that part of your story.
Hmm.
How you're a tax-paying citizen
Focus on
might be
them.
what their interest is versus,
Yeah.
the life that you saved and what you give back in the community. Some people want to see that you're saving taxpayers' dollars.
Right.
Other people want to see that you're saving lives.
What's the bottom
It's all
line?
still valid, but that's where you've got to, again, not take it personally. And that's how people get burned out is like when they, have some humility, but
Mhm.
keep sharing your story.
Right. You asked me earlier about, training and coaching and things like that. And do I miss it? Yes, I miss the training. I always miss the person, the naysayer in the room. Like they would be the person,
Yeah.
how they say when you're doing public
Yeah.
speaking,
Yeah.
like focus on someone or something in the room. Well, I would focus on them because you could tell in their body or their
Yeah.
facial expressions, I'm only here because
Yeah.
I was told to be here or
If you can
whatever.
win them over, you've done your
Yeah,
work.
and
Yeah.
and I'll go up to the table and I'll be
Yeah.
like, "So, what do you think?"
Yeah.
But that is, always just staying focused on on the agenda and not making it about my agenda. And that was a practice I had to learn for a long, long time. Taking my lived experience and integrating it into not only the professional, but how I wanted it to show up on a different platform than a church basement.
Yeah.
And that's,
Yeah.
Anonymous People
Yeah.
was the first
Yeah.
for me.
Good friend Greg
Starting the
Williams.
Reach Out
Yeah.
Project
Yeah.
in Milford, starting my own nonprofit to be a
Yeah.
hub for families and individuals to go to that felt safe, that knew me in the neighborhood
Yeah. Oh, yeah.
and that's how I got the job
Yeah.
with CCAR, because I had talked to Phil about my nonprofit, and that's how I
Yeah.
got the call. And am I interested? I'm like, yeah, I'm interested. It was my actual first job outside of doing administrative
Yeah.
assistance and things like that.
Yeah.
So, what is the plan for liberation for overdose awareness?
Oh,
What are you all doing?
well, we do a lot of different activities. The community here hosts, and again, it's the community that's empowered to host it.
Mhm.
And we come and we usually show up with our peace, love, and liberation vans that are, they're all psychedelic. People think we're selling acid out of them, but
Oh,
we're actually bring those to all the different communities that
mhm.
we're going to provide events for, and throughout all of Recovery Month.
Yeah.
Probably the most successful, though, one that we're able to partner with, and is the New Canaan Vigil. And I've been honored.
Oh,
This is the
yes.
10th year, and I've been
That's the
honored for the last.
parent.
It's Paul Reinhardt and
Yes.
the New
Yes.
Canaan parent group that actually
Nicole goes to
started
that.
that, and it's
Mhm.
incredible. And I think it also speaks to, like, how do you get your voice out there?
Mhm.
Paul Reinhardt started it 10 years ago, and I've been honored to be the MC for the last, this will be the 10th year in a row.
Mhm.
And it started out with having it be an awareness, and he lost his son from an overdose, and he shared that story, and we had maybe 100 or 200 people, but it's grown now to last year. There was close to 600 people.
Mhm.
And why does he have that happen? He invites everyone. He invites all the local administration, the local law enforcement, every faith community actually participates, and the recovery community. And the other piece of that is that he doesn't wait till, again, it's this one is on September 1st this year.
Right.
But, he doesn't wait till like August to plan it.
Mhm.
After we have this event on September 1st,
He's
probably the
already in the
next
planning
week, we'll have
process.
a briefing. What can
Mhm.
we do better? How
Yep.
can we bring more people in?
Right.
And he has a planning process throughout the year. And that's why I think it's so successful. And for such a small town as New Canaan, he could bring close to 600 people in the community together to be able to celebrate recovery. And so he's expanding it beyond just overdose awareness to also offer hope and faith for people that still may be struggling out there.
That's awesome. I think of the one young person, one of the two young people that when I worked at CCAR as the Young Adult and Family Project, Allie. And
I know Allie.
yeah, I know Allie. And to see her uh, start with me at that point, that was 2016. And here we are 10 years later. She's 10 years in recovery plus, a mom, a wife, and has spoken at Paul's event. Um, and she also had her family, and her family was the first
Yeah.
family that
Yeah.
came in that I worked with. So we get uh so much education just from being out. That's why I don't want to go back to college in
Yeah.
the sense, because my education is the streets. When I literally, this whole area, State Street, Fairfield Avenue, is where I was in active use. And so to come when yeah, I live in Milford a couple towns over, but every time I'm coming here, yes, the remembrance and the gratitude that I feel that, wow, I have gone full circle. And I I'm glad that I didn't come into recovery during the height of the opioid crisis, because I don't think I would have survived
Yeah.
under certain circumstances. Uh,
I remember many years ago, just
yeah.
wanted to mention that I was in a meeting with you. We were in the Valley, and the commissioner for Department of Mental Health and Addiction Services
Mhm.
was there, and all the town officials and all the community providers and all the supposedly experts in the field and therapists and treatment providers were there. And you were just quietly in the back of the room, and you came up with the idea. what if we put a recovery coach in every emergency department? That probably would save lives. And of course, now it's like the national model.
Yeah.
And you were the first person to come up with that idea.
It's funny because I think that was the second time that I had spoken about it out publicly. Well, the first was actually having the former commissioner sitting next to me. We were in oh gosh, we were in New London. We were at the not treatment, outpatient methadone clinic or HIV clinic
Mhm.
that was there, and go Senator Blumenthal was there, Gary, was it Mendel who lost his son
Yes,
from
shatterproof.
Shatterproof, was there, and, we were all kinda crammed into a space about this, but there was a lot of people, and Pat was sitting next to
Pat
me,
Raymond.
and
Yeah.
she was working at Hartford Health, and, she had transitioned there, as a BP? I think she was
Vice president. And she
BP.
listened to you.
And but this
Yeah.
is the thing, she knew I was actually had Allie, and I had this young, man, the 2 young people that I had with me, and she said to me, she said, "We have some money. I'm not quite sure what I'd like to put it towards recovery, and, but I'm not sure what that would look like." And I said, one of the things I wasn't the one that was at the hospital, having had an overdose. I was, lucky not to have gone through that path. But listening to Gary talk about the loss of his son and his experience, I said it would be great to have recovery coach. I don't know where I heard that from. I knew it wasn't a new concept. Massachusetts was already
Mhm.
doing it. But it was just something in conversation. So she said, well, have Phil contact me.
Yeah.
And then I think you were the second person that I talked to about it, and you were also the president, for CCAR. So and again, it didn't launch for another couple of years, and I wasn't working for CCAR
Yeah.
anymore, but just to watch to see now we're in what,
Look at it. Yeah.
20
Yeah.
plus
Oh, I think
hospitals?
every hospital in Connecticut.
Every
Yeah.
hospital in Connecticut, all 3
Yeah.
shifts. Again, I'll drop in an idea. If you take it
Yeah.
and run with it, you don't have to attach my name to it. It would be
Yeah.
nice,
But they did.
but
They did run with it.
yeah, they ran with it.
Yeah.
And it's beautiful to see. As a person, I struggled, my addiction started back in New Jersey, and then I gravitated to geographical
Yeah.
cure to Long Island, and then
Yeah.
eventually out here. And, you know, uh, um, actually in October, I'm going to be talking about transformation. Next month in September will be about purpose and legacy. I don't think folks that come into recovery think that far ahead. That's the what's next for
Yeah.
me. It took me many years to have to break through some of that other stuff because I had to work on not only stabilization, but also celebrate myself
Yeah.
in recovery. And we talk a lot about that in the recovery coach training.
Oh, yeah. What is
So
it? Victor
yeah,
Hugo said that no army is as powerful as an idea whose time has come. And you were the one that introduced recovery coach because its time has come and look how
it
it's
is.
taken off.
It
Well
is.
done. Well done, Carol.
Thank you. Thank you. My mother actually said this is a new age of recovery. Or, she was talking about the people she knew in 12 step. And she said, people need to open your mind about mental illness, mental health. Yeah. So we've changed. It's definitely getting better. So as we're wrapping up, and thank you again so
Well,
much,
thanks for
John,
having me.
for having me here. Just looking into the next 5 to 10 years. I
Okay.
know that's a little bit
Yeah.
of a projection. What would you, or what would a recovery system without limitations look like?
I think it would look like an ongoing support for chronic disease as it should be, fully integrated with any other chronic disease and giving people help and support and different pathway choices over time
Yeah.
in a non-judgmental way. Again, meeting people where they are. I think the best model I've seen so far that looks most hopeful for that, and you mentioned anonymous people, is Greg Williams has this
Yeah.
model of incentivizing recovery and not relapse, because
Hmm.
right now we don't do that.
Right.
And his model would be having a hospital, for instance, be the hub, and then the spokes of the model be specialty care.
Mm.
So have a model that has the whole community involved, and that actually is covering people, through the lifespan, and
Mhm.
then starting. I think what we need to do, obviously, even our agency at Liberation, it's we got our name 52 years ago because we liberated the community from the scourge of drug addiction, which sounds pretty pejorative. However,
Your cape's
again,
on.
yeah, I know, right? It made us too empowered. We need to be a little more humble. My friend Jimmy Gita used to say, "I'm not taking credit for anybody's recovery or anyone's relapse. That's their work." And again, that's what kept him in the field 40 years.
Mhm.
So the idea of where we've come in Liberation, it's really all prevention. It's prevention on the front end by advocating to build people's looking addressing the social determinants, having people know mood regulation, self-regulation, build agency, have them feel lovable, capable, and connected with our prevention efforts. Our treatment is really relapse prevention and recovery management,
Mhm.
and then our outreach efforts is preventing people from dying and trying to keep
Right.
them alive till the miracle occurs. So it's that simple. That's what all models should look like, and it
Mhm.
should include meeting people where they're at to give them whatever they need, whether it's housing, whether it's harm reduction supplies, whatever it takes to keep them alive. And it's about the building the recovery capital is about building that relationship. And then you could be the lifeline for somebody. You never know if you're that lifeline for somebody until you find out later. Sometimes I
Right.
find out years later that I made an impact I didn't even think I made. And it's just incredible how sometimes it's like a little like act of kindness is what people
Yes.
remember. I remember like I saw a client from like 30 years ago, and they remembered that I went outside my office in my private practice. I held the umbrella so they wouldn't get wet.
Mhm.
They remembered that. Then all these like fancy interventions that I had,
Yeah.
the Carl Whitaker used to say that he was a family therapist. Says the techniques are what you use until the therapist shows up in the room, and the therapist is just there to show unconditional love.
Right.
So at the end of the day, I want to continue, no matter where you meet people, meet them with dignity, respect, and unconditional love, and we'll have a great system of care.
I love that. Thank you so much, John. Thank you for your leadership, your friendship. Thank you for everything that you're doing here at Liberation. It is liberating. It is evolving to where you're giving people chances. You're giving choices. Giving them a chance, learning how to be open minded and also curious about what it is that I need. And some of us it has to start from the bottom up and be patient and have know that there's someone handing me a hand up versus a hand out. I think again that removes the stigma and the bias around
Absolutely.
addiction, and yeah, just helps people to know that there's an open door policy
Yeah.
always.
Yeah.
Maybe not in every place that they go. Again, we can't control what other agencies or what other treatment centers do. Hopefully they look at your model here and look at the small parts before we can even tackle or look at the bigger parts. So
Absolutely.
again, thank you so much. Thank you
My
for our
pleasure.
audience
My
for
pleasure. Thanks
checking
for
us
having me.
out. Yeah, so keep cruising, keep working on yourselves, and yes, until next time, thank you so much for being on
Bye,
Cruising on
everyone.
the Edge. Bye.